But quickly, oh yeah, just to note that we are recording this session. There's been a lot of interest for people who are not able to attend for us to share the session later on. Thank you so much.
Gloria, I'm sharing it in the comments.
Oh, in the comments. Thank you so much. So, as I said, it's my honor and privilege to chair the session. We do have apologies for some of our members. I know that Dr. Vincent Pagiwa could not join. He had another urgent meeting that he had to attend to. I don't know if there are any other apologies that I should note. Right. Okay, we can just perhaps put them in the chat box if there are any other apologies that should be noted. So it is an honor and a privilege for me to introduce our speaker for the day, who happens to be a colleague of mine. Professor Matthew Chosick is a research professor in the Climate and Health Directorate at Witwatersrand University of the Witwatersrand, South Africa. He has worked on public health research across Africa for around 20 years and with WHO and other international organizations. After medical school at the University of Witwatersrand, he studied public health at the London School of Hygiene and Tropical Medicine and doctoral studies at Ghent University, Belgium. He's leading NIH Heat Center project on data science and climate change, and is also the co-lead on the Wellcome Trust grant called HAPPY that examines the effectiveness of adaptation interventions. Matthew's topic today is indicators for tracking the impacts of climate change on health. Do we need attribution indicators? Welcome, Matthew, and over to you.
Thanks, Gloria. Let me just make my screen full 1 second. Have you got a full screen? My computer's getting old. It should become...
Yes, not yet. We still need to put it on PowerPoint.
Is it on PowerPoint?
Not yet.
And now?
No. You're now showing your emails. Go back to, yeah.
Okay. So my computer's a bit... there you go. Okay.
There you go.
Okay, wonderful. Thanks, Gloria. And thanks, everyone. It's great to be here.
And just before you jump in, Matthew, just to let everyone know, we'll let Matthew do the presentation and then we'll leave some time for Q&A after the presentation. So please do take notes, and I look forward to a session where we all engage. Thank you.
Excellent. So I'm talking about attribution, and that's where you split the impacts of climate change into those that are from natural variation in temperature, or in climate, for example. We've always had floods and heat waves. So that's a natural variation, but then we also want to look at what are the impacts from climate change itself. And people are familiar with attribution when it comes to a hazard. So, for example, when there's a flood in KwaZulu-Natal, everyone wants to know, was that flood from climate change, or was it a chance occurrence, a natural flood that had occurred for millennia? So that's what attribution is about. So just to take one step back, so why do we need indicators? And often indicators or monitoring and evaluation is not the most exciting part of science. People interested in which intervention works best. If you want to present on indicators, you're unlikely to get the plenary session at a conference. But I think from a health system point of view, this is really at the heart of trying to make progress within the health sector. So at a district level, you need indicators so you can plan which condition is causing the largest burden of disease, or which part of a district. So it's really around planning. At a national level, it helps if you have measures of different conditions and where they are and how bad is the burden, etc. That helps you with directing the national resources, but also trying to set targets at a national level. And at an international level, similarly, it helps to set priorities, what makes it to the global policy discourse, and again, international targets. And with HIV, every few years, they made a new set of targets, as an example. But I think beyond that, practically in our communication with the public and with civil society and with policymakers, if we have clear measures of burden of disease or of progress with adaptation, it helps us to communicate and to advocate for changes and resources for climate change. And I think once we have really strong indicators able to measure the real impacts of climate change, that will bring our leadership to the fore. So there's a number of factors that determine whether an indicator is valid or robust. When we select indicators, we need to think about several factors. So you want something that's valid and that measures what you are interested in. And in this case, it would be the impact of climate change. So it's valid and it has to be feasible. So the data should be easy to collect, ideally from routine services. It's timely. So you would, for example, when there's a flood in KwaZulu-Natal, you want to know relatively soon afterwards, is it due to climate change or isn't, or is it just a natural variation in temperature? If that calculation comes a year later, it's not that useful. So really we want timely and real-time impacts. Must be understandable to the public and to science, and you'd like to disaggregate it by place and population. So the vulnerable groups. As in climate change, we really focus on who the vulnerable groups are, and you understand that by disaggregating your indicators or results. It should be actionable. In other words, once you've got that measure, it would be ideal you would think, okay, I've got this, and therefore I need to do X. And you want to track the full extent of climate change. If we have an indicator that only tracks a partial or one small aspect of it, that's not really capturing the whole burden of climate change, only the partial. And of course, weather, which is a little pun on the weather, but it's weather and impact. Who is it affecting? When, where, and to what extent, and why? It's kind of the 6 W's. So when you have an indicator, there's 5 decisions one needs to make. What health outcome or outcomes are you measuring? What is the heat exposure? So I'm talking about heat. Obviously, the same principles probably apply to infectious diseases, to social impacts of climate change, for example, and of course to natural disasters or extreme weather events. So who is your target population? What is the time period about your indicator, and what is it geographical unit? And as I already said, it might range from district or even sub-district or even facility up to international level. So I think there's 4 types of indicators I'd like to talk about today. So the first one is around exposure. And I'm using pregnant women as the kind of illustrative population, but you could equally apply this to the elderly or to homeless people or to other vulnerable groups who are particularly affected by climate change. So exposure just measures how many people had experienced temperatures above a certain level which you've decided is dangerous. So it doesn't tell you anything about what happened in that exposure and were they able to cope with that exposure. In other words, was the air conditioning throughout that area, and then you don't know what the impact was of that exposure. Perceptions of heat is also, I think, quite useful. Do people understand the dangers of heat? And we know that this is a problem, that there's low awareness and attitudes around high temperatures in pregnancy, for example. Then of course, you want to know is there access to interventions to reduce the impacts. And this is often, you call this the 2 C's. In other words, are there contacts? Do people go to services when it's hot and they've got problems? Or do they attend antenatal clinic or others, or rather don't attend services when it's hot? And we've seen that in some studies that women, even during childbirth, if it's extremely hot outside, they would favor home deliveries over going to a facility if transport is an issue. And of course, what are the contents of care? What interventions are available? And then the 4th one is the focus of this talk, and it's around what are the impacts. And impacts are both the effect of climate change, but also how well have we adapted to it? So when you look at health outcomes from heat, you're measuring both the impacts as well as how well is the health system responding to those. So to start with the first one, this is around exposure. And I'm kind of modeling this on the Lancet countdown, which has been at the forefront of indicator measurement for, I think it's 9 or 10 years. Yeah, has really framed and has quite a similar system to the 4 categories I'm presenting today. So here it would be, for example, the number of pregnant women and infants in South Africa exposed to dangerously high temperatures. And this is relatively simple to calculate, especially now that we have the census data, which will come down to enumeration levels. Enumeration units. So that's really sub-district, quite local level. You'll be able to know how many children, for example, under 5 lived in a certain area. You'll be able to know in that area what are the temperatures, what is the weather in that area. And then you'll know, for example, there's X number of dangerous heat days in a enumeration area, which is a small geographical unit, and the number of children exposed to that particular dangerous days. So I've tried to look at the bottom of each of these slides. So this indicator is feasible, it's timely. You can tell us the same day even how many children were exposed during a heat wave to a dangerous temperature. It's understandable. I think people can understand this. And of course, you can do it by place and population. But it doesn't track impacts. The second one is awareness and attitudes. Like I mentioned, this is important. The public have generally have quite a low understanding of climate change. And you still have the odd character who spreads disinformation, which, there's conspiracies and all sorts of problems which remain in awareness and attitudes, and even from people who otherwise are seemingly intelligent, they have quite strange attitudes towards climate change. So, for example, here, one would take the Twitter feed in a country, let's say Malawi. You would take the Twitter feed, and you would work out, you would calculate how many of those tweets were on climate change, and of those on climate change, how many covered heat in pregnancy. And this you could do changes over time. And you would hope that over time you would see, additional mentions and valid mentions of something like the dangers of heat in pregnancy. So again, I think this is feasible. It's timely. This is real time. Social media is real time. It's understandable, maybe, and perhaps it's actionable if you are seeing some kind of misinformation being spread. One could action on it. And social media you can disaggregate by meters, I think. But it isn't valid. It doesn't measure what we're after, which is the burden of disease. And Lancet does media engagement with health and climate change. So they would look at the global newspapers on so what they do is look at the global newspapers and how many of those were on climate change. And then of those on climate change, how many covered health as some aspect? And this is quite surprising for me that they were saying around a quarter of all newspaper articles on climate change do mention health. That's higher than I might have thought. And I feel sorry for the person who had to trawl through a lot of those newspaper articles to make such a classification. Although I imagine it's done by artificial intelligence or machine learning or similar. So, okay, so now we're talking about something getting a little bit closer to kind of heart to the matter. How are we doing? So 3A, I've got a few slides on this. The first one is access to, so we're talking about access to interventions. So one of the indicators that has been used for really years and years was, is there a health adaptation plan in place? So that is something that's quite easy to measure. So that's why it's been such a popular measure. So obviously the problem is here, you may well have a solid plan and a very well developed plan, but no one knows if it was resourced. This indicator, doesn't measure if that plan was resourced, doesn't measure coverage of that and impact of it. Did the plan work? So for me, this indicator has some use, but You know, you don't know by place and population within a country. It's got, sure, it has every country as I would hope is moving towards having a plan. So there is some value, but it's not something I would use as an overall measure of impact, but I think perhaps useful. So now we're getting, and this is something that Chance Network is really, I would hope, is at the heart of all of the activities in the Chance Network. For me, this is really one of the things that this network is about, and that has the potential to influence and to drive, in fact. And this is a nice indicator, I think, that the Lancet uses within their measures. So they would say, they look at global multilateral funding, and they target the Green Climate Fund. There's also the Adaptation Fund. There's Jeff, there's probably, I don't know, I would imagine there's around 10 of these kind of funds. So these are funds, in the case of Green Climate Fund, that's where countries have given money to this fund, and that fund, which is based in South Korea, then disperses it to those who have applied, and you get money to run a project. Some of these can go up to $100 million size in project. And this is really the key global mechanisms for countries to access funding at scale. It's I guess you could say it's similar to the Global Fund for AIDS, TB, and malaria, which is a very highly functional global, and it's really was driven, and it's based in Geneva, so I think it is important where these funds are based, and it has been a highly effective mechanism. Whereas the Green Climate Fund, I think, is still finding its way through some of these challenges. So the health sector, that's 205 million, has been somehow related to potential health benefits. So that might be some indirect. So, for example, a water project, they might say, well, part of this water project is around health, or a nutrition project, yeah, you know, that is partly around health. But this isn't really direct health services. This isn't around getting a health facility and doing something. So a lot of that's indirect funding. And in fact, only 0.2% of international financing goes towards health. And that's very strange, because we are good at spending money, and we have a solid set of interventions that we could intervene on. So I think this is really an excellent measure of how are we doing as a health sector. So the second one is, what are the access to intervention? So this is something called lethality. So how lethal is an event? So something like a flood and a storm is something you can measure the number of deaths, really. So the box at the bottom left, this is a Lancet indicator of how lethal was an event, and that does make sense intuitively, that if your services, if your emergency responses, if your protections, you know, against floods, against, you know, the low-lying areas, if you've begun to reinforce, if the drain pipes are working, those extreme events will have lower mortality and perhaps morbidity or hospital admissions. So within very high HDIs and high HDI countries, there is a decrease in the lethalness of a flood. For example, when it used to be 86 deaths per flood, it's now gone down to 16, and from 11 to 8. So that does show that those countries are coping with extreme weather events. In the lower HDI countries, there hasn't been a change. So that shows there's already clearly some place that we could intervene. So the area that I think, if you're doing maternal health, you might say that during the heat wave, was there, how many preterm births were there during the heat wave per degree, or you have some measure of, because we know that heat waves cause really a spurge or a spike in preterm births. And if you're getting less of a spike, then you can infer that people have access to some form of an intervention. And you have seen this in many parts of the world, where they used to get many more deaths during the heat wave, and now when there's heat waves, you almost are getting none or certainly much fewer deaths in people aged above 65, for example, because there is, and this is largely due to cool spaces like air conditioning. In other words, if there's a heat wave and everyone in the population has air conditioning, you'll certainly get less deaths than you would have prior to that level of air conditioning. And of course, air conditioning is a complex topic. So I'm talking about the exposure response curve. I'm not going to go into this in detail, but this basically says at a particular heat exposure or temperature exposure, how many adverse outcomes are you getting? So exposure and response curves, and these are really important within indicators. So the next part I'm talking about here is around impact. So the preceding ones, remember, the first was around exposure, the second was around attitudes, the third was around interventions. The fourth one is now pure impacts. And of course, impacts again is a mixture of how well are we doing and also how bad is climate change. So one of the perhaps easiest ones is the percentage of something like hospital admissions. Or visits to a casualty department, because we know that when the warmer it is, the higher the number of health conditions you get, and this ranges from increased number of suicides to violence to gender-based violence. Almost all pregnancy outcomes are increased when all adverse maternal and child health outcomes increase with temperature, mortality amongst elderly. Certainly infectious diseases like gastroenteritis, a whole range of these conditions increase, and many of those do lead to hospital admission. So if we had a daily, and I put the word daily there because this is so important, if you had the number of admissions on day X and you know the weather on that particular day, you can work out, are there more admissions on warmer days? And there's one study from Cape Town, and this is interesting. Here, when this was during a heat wave, so if there was a 0 to 1 days of a heat wave, you would get a 3.9% increase in hospitalizations from cardiovascular disease. If the exposure was at a longer period, you were getting an increase of almost 6% of admission. So this is something, and respiratory diseases were also we're also dependent. The number of respiratory admissions was also dependent on the duration of a heat wave. So this I think is something that's relatively easy to measure. So our area that the team focuses on is maternal and child health. So here you would look at the number of heat-related preterm births in District X. And here, again, if you know the number of preterm births on a particular day, the weather on that day, you can work out if there's more preterm births on a hot day as opposed to a cold day, and therefore how many additional are you getting in District X. That helps you to direct resources, and it tells you how well are you helping women to adapt. And there's another example of obstetric emergencies. Are there more cesarean sections when it's hot? And that's how you might measure impact. But all of these, as you can see, are around temperature, around high temperatures. And we know the temperature is a mixture of natural variations, perhaps seasonal variations, things that have occurred since the beginning of the world. There have been variations in temperature, but also the heat from climate change. So this is the indicator, and this is about attribution. Where you want to know when you report to the public, when you're discussing how much money you need in the area, when you're trying to understand which group is vulnerable, you want to know impacts from climate change. So, and that's now you've removed the impacts from natural variation in temperature, and you want to say something like the number of preterm births from climate change in an area, or obstetric emergencies from climate change, and I think that that's really at the heart of this talk, and I'll go into more details in the next few slides. So I just wanted to show again, when we do these kind of measures, you want really daily data on these indicators, on things like admissions or on preterm births or cesarean sections, etc. So you know, some people say no, you can use monthly or district data, and sorry, you want to know where these occurred. So you need to know what facility, for example, these occurred at. So you need small geospatial and temporal measures. You need, ideally, because weather we know up to 30 meters, or from modeling you can say the temperature in a 30-meter area versus the next 30 meters will have a different temperature and weather profile. So I'll just give you an example from Ghana, and here they used monthly number of stillbirths. Okay, so they had in a district. So this is a very large area, and they used aggregated data because, like Bono and others know, in a health system, many of the data that a facility reports is at a monthly level. So they'll tell the Department of Health, okay, this month there was, this month there were 1,000 stillbirths, but not by daily. So they did in this, even though it was monthly reports and at a very high geospatial level, they did show that heat caused increased stillbirths. So you can demonstrate it, but there's a lot of error, and this doesn't help. You really are losing so much information. You will be able to publish a paper that shows that in District X, when the temperature at a month is on average 25, you did get an extra few preterm births, for example, but it's not the kind of information that'll get an article in a journal, but it won't help the district to plan services and the country to decide, because there's just too much loss of information. But you know, it is something that there is some value if in kind of worst case scenario if you can't get daily information. So a lot of the work is around, here I want to go into what kind of condition would you measure, and in many high income countries they look at deaths in people above 65 years old, and how do those increase when it's temperature, when it's warm, and therefore if there's less deaths during hot periods, then that's a marker of some way that you've responded, a country or an area has responded to the dangers of heat. They've adapted, and you're getting less deaths among people above 65. And death is relatively easy to measure. Most deaths are recorded, but it's there's problems with this measure. It doesn't always inform you what you should do, and in many countries of the world, the life expectancy is under 65 years. So I think there's a push towards having indicators of morbidity rather than mortality. And here I give an example of preterm births. That is I really think one of the focus conditions. This is a systematic review that Darsnik and Laku and others are working on. And here, the most striking feature is that there were around 200 studies. 84 of those covered preterm birth. And most of those, so that's in red, found an impact of heat. In other words, when it's warmer, you get a more preterm birth. And I think there's definitely a very strong signal there. And there's also, so there are some studies on stillbirths and many other these events. But I think really preterm birth is a critical exposure. And we know outcome. And we know that gestation is hard to measure. So there's a lot of error, but nevertheless, you are finding that kind of outcome. So in these study locations, as sadly is very often the case, there's a very skewed spread across the world of studies. And around 49 of the 200 studies were in the United States. There's now a lot of work in China, so 33 of the 200 studies. And within Africa, there's really just a handful, but are increasing over time. There is in Australia as well. So as more evidence accrues, and that's also part of the indicator work, that if we are measuring more around heat and preterm birth, we'll increase research and we'll help to direct resources. So in other words, if the Green Climate Fund is trying to figure out how to direct resources to climate change, if it has only 2 studies and it hasn't got any routine measures, it's quite hard to justify doing a program targeting pregnant women. You know, they'll say, good, I can see that in America, heat causes increased preterm births, but how bad is it in Africa? And why is preterm births more important than something like gastroenteritis in children, which also is very temperature sensitive? So we do need this evidence from countries in Africa, and you do need indicators so that you can justify responses. So, like I said, with attribution, this is a very simple graphic that I hopefully captures this topic. So all of disease in the world can be separated into those related to heat or to climate, and then those that are not climate sensitive. So there on the right hand side it says heat, but it's yeah, let's just say heat on the right hand side. So some portion of all disease in the world is due to heat exposure, and that's what we've measured in those 200 studies. They measure how many do you get from heat, but heat needs to be separated into background or natural variations and climate change. And this is in the climate field. This field is really improved markedly. I'll give you an example here where this is around the temperatures every September for 60 years. Okay, so the temperatures from 1940 to 1980 fluctuated in Septembers. You can see the red line. Every September there was a change. Some Septembers, this is the world average. So in some Septembers it was slightly lower. There probably a range around the 0.5 degree mark. But from the 1980s, the September months became warmer. The little black dots are new records. So in other words, in 1980, everyone was very concerned because this was now a new world record for September. And then almost every September after that set a new world record. And so you might be able to say from one black dot to the next, wow, this has gone up again. And is this due to climate change, or is it just a random shift like you've always had before? And you might say each of those dots, we'd probably be able to make a conclusion that no, the Septembers are going up in a linear fashion, and almost certainly due to climate change. But this September, sorry, the September that has just passed is not following that linear progress. It's something quite different. And so here the question is, that change, that step change in 2023, was it just this slow progression of climate change, or is it representing really something quite different? So here they would work out, and they showed that there's a minuscule possibility that the September 2023 record was that slow progress was the same as those change over time in temperatures. There's really something particularly different about the September. It's not a natural variation in temperature, and it's not the natural the increase in temperatures over time. So within health, you have to take 2 steps. The first one is to do something similar to the preceding slide, where you say, has climate change, and here it's showing the top left, from greenhouse gas emissions, has that changed the climate in an area? And that we know from things like floods or the preceding, that's been done. That's a hazard. Then the next question, you have to take it a step further. Has the change in climate from climate change caused an increase in hospital deaths? In whatever your outcome is. So it's a 2-step process. It has to answer two different questions. Well, let's skip that one. Okay, and at the heart of these calculations, it's called the counterfactual. So in other words, so on the left, this showed in the heat number of heat wave days per year in this is a study from China, and the number of heat waves is going up. It's not year on year, but there's certainly an increase from around the 1990s. There's this increase in heat wave days per year. You then have to, the blue line on the right-hand side shows what was the patterns in weather that we would have expected due to natural variation alone. And then the gap, so then the gap between this expected weather and what you saw, this gap between here, is then the amount of heat exposure that we can attribute to climate change. This area, the gap here, tells us then there was an additional number of heat wave days. And therefore, the heat wave days from here, how much health burden did that result in? And this then gets translated. So from the previous graph, you would be able to say that, just as an example, there were an additional 100 heat wave days in China that was attributable to climate change. You then can make a graph like on the right-hand side. So the left-hand side of the screen, it tells you how many preterm births did there were from heat. And you can see there's a geographical variation. In some areas, there was 1,700 to 2,000 additional preterm births from heat. But then on the right-hand side, you show how many preterm births did you get from climate change. And those numbers are obviously smaller. So the darkest red on the left was some province that had between 1,700 to 2,000 from preterm births from heat. On the right-hand side, there were 900 to 1,100. And the remainder, the difference between 900 and 1,700 and between 1,100 and 2,000 was due to natural variation. So we need to get attribution right. And so this is really why is attribution so important. And I think one of the key things is the communicability of our messaging. So we want to move away. I've always struggled to describe heat causes suicide. Because people say how hot is hot and does heat really do this? If we're able to say that climate change causes suicide, that really helps us to communicate. And we can track the impacts in adaptation, progress, and the health sector performance if we know measures. So in other words, if we're still getting throughout the world 100,000 preterm births from climate change, that tells us how we're doing. It's really a tangible, palpable measure of how is the health sector doing. And the third reason is that to secure funds for loss and damage and for climate financing, like the Green Climate Fund, you need to be able to show the burden from climate change, not from heat alone. And then again, you want to be able to track how have you shifted the burden from climate change and not from a hazard. And then the one of the major things driving this field is that you want to be able to take a company like BP or Shell to a court and say that, okay, you're responsible for 2.5% of global emissions ever, and therefore you need to be covering 2.5% of the costs of climate change. And if before, when you spoke to Shell or to a country like the United States or one of these high emitters, and you said, you need to start paying for the damages that you've caused. And why should a country that has emitted almost very, very low levels of carbon dioxide, why should they be suffering and using their scarce resources to kind of recover from a flood, for example? And then those countries who are responsible for climate change need to pay for these loss and damages. And that will not work until you're able to go and describe the burden from climate change alone. But really, the more we understand this, there'll be so many new applications. So this list of bullets is primitive because we don't really have yet attribution evidence. As it accrues, people much smarter than me will add additional bullets and new novel ways of using this information. So this is the kind of step changes in the field that we need. The bottom where we started is around heat impacts on a seasonal scale. And there's still people who publish articles to show, look, in the summer, you're getting more schizophrenia than the winter or the spring. And those are important still. But that is really the kind of work that was done almost 460 years before Christ, where the seasonal impacts were already noted. Whoever wishes to investigate medicine properly should proceed thus. In the first place, consider the seasons of the year and what effect each of them produces. So, so season is really at the bottom of the kind of measures, and then the daily scale is what's currently done. And there's a lot of studies and many research groups throughout the world, including ours, are producing these kind of, when it's hotter on the day X, you're getting additional number of motor car accidents, etc. But then the next level is around attribution, how many of those motor car accidents were from climate change. And then you want to project going forward, what will happen if we introduce white roofs in an area? How will that reduce the number of deaths among those above 65 years? You want to be able to project the future, but also understand what happens if we do X. And then we're lining up with an indicator that really captures climate change and has hopefully all of those criteria that we've discussed. I like to view this as different generations of indicators. The first generation is where we would look at something like infant mortality in a district and try and say that, okay, in this district there was a flood and infant mortality went up a little bit, and that was probably due to climate change. That's really like a first generation, because of course infant mortality is affected by, I don't know, probably 100 different factors, as is nutrition and hospital admissions, etc. So the second generation is the impacts of heat on health. And then, of course, the third generation is around the impacts of climate change on health. So I think this is generational shift. Of course, this whole system is much more complex than I've discussed here. And you want to be able to measure each arrow on a figure like this. So and we do have good measures. So how many, what is the greenhouse gas emissions in a particular year? How has the climate changed? And that's where a climate scientist, and we're fortunate to work with many excellent climate scientists who are able to show changes in climate, like temperature, etc. Each of these obviously depend on vary by climate zone and geography. And of course, that the climate zones and change shows what kind of hazard does a particular area have. In other words, what changes in precipitation and temperature, etc. And then how do those impact on different populations? That's the health impact. It also impacts in the natural world, and that is affected by how vulnerable you are. Do you have air conditioning? Do you have white roofs? And sorry, vulnerability is around this, factors like poverty, age, etc. And how well have we adapted? So this is what you would ultimately aim for. So yeah, presenting work that has, this is a large team and several projects which have where we, they have provided funding for the work that has been presented. Gloria, back to you.
Thank you, Matthew. That was a very fascinating, fascinating discussion. It's clear that now's the time to focus on getting the indicators right, and getting the you need to get the attribution also fine-tuned so that you're able to attribute the changes to heat and climate change, as you say, as a third generation, and then linking that to funding so that we hold the world accountable for greenhouse gas emissions, particularly in Africa. So this is a fascinating presentation. Thank you so much. And just to say that to everyone else, I've seen requests in the chat for the slides. We will make sure that the slides are available to everyone after the session. If you have any questions, please raise your hand. There are questions in the chat box. Perhaps, Matthew, with the time that's left, we can just unpack that. And these are two questions from Fortunate, around the thresholds and also the standardized definition of heat waves. So maybe just the first question, and I see you've got, discussion, but anyway, let's go to the questions. Fortunate is asking, how's the threshold for dangerously high temperatures determined, or what is the threshold in indicator tracking exposure of pregnant women and infants in South Africa? and what methods are used to account for the regional variations in temperature exposure, as well as varying levels of vulnerability among different populations across the country. And then I'm just going to go to the second question as well. She asks, regarding the indicator that tracks the change in preterm birth during heat waves based on daily birth records, could you clarify the specific criteria used to define a heat wave, given that our current discussions in Zimbabwe highlighted the necessity of standardized heat wave definitions for health sector tracking? I'm concerned about potential inconsistencies in data and difficulties in making comparisons between different districts and countries without a uniform definition. Additionally, how does the indicator account for disparities in infrastructure, healthcare accessibilities, and other social determinants that could significantly affect the impact of heat waves on maternal outcomes? It's a mouthful, but maybe let's unpack the two, the thresholds and the heat wave definition. Over to you, Matthew.
Sure, and I think it would be if other people in the room have worked on these topics also for many years, and I think if people can come in and add your perspectives, I think that would be very useful. I think anyway. So I think these are very difficult questions, and this is what we're showing about good science. The more we understand the science, the more we start doing these measures, the better they will become, and we really need to start them. So the thresholds vary. It's complex science. So the temperature above which you start to see something like preterm birth depends on climate zone. It depends on your background level of adaptation, for example. So it's complicated, unfortunately. So in some of the countries in the Arctic, when there was one study when it went above 8 degrees, you started to see abnormalities. And in other places in the world, when you're above 35 is only when you start to see these health impacts. So unfortunately, it's complicated. But if you did have data on a district at daily measure, you would be able to work out that threshold in that district, and then you would track that over time. So in other words, if we did have the metropolitan, if we did have daily number of preterm births in the Johannesburg metropolitan area, in year one, you would be able to figure out above what threshold are you seeing these impacts. And then you would know then for the future, the subsequent years. There's, of course, a lot of modeling in the world that is done. And a lot of this has to be modeled. And so I guess there's some alternatives here. You might make a sentinel district where you focus on monitoring something very carefully. Choose a higher risk district and monitor as closely as you can. Get that data clean, set up the systems. You have to harmonize the daily temperature with perhaps even humidity and a few other factors with the outcome. So get some districts right, and then you can use that information for other districts. I'll give you an example of how the Lancet Commission does this. They say throughout the world there was a certain number of deaths in people above 65 from heat. Okay, and they'll work out. They model this information by saying how many people above 65 are there, and from studies throughout the world, how many at what temperature are you seeing these, and then they're applying that to the world. So it's a combination of knowing things perfectly, which I think we can get to if we have solid information, but also being practical and modeling. Everyone who worked in HIV, remember on World AIDS Day, we say there's an additional 200,000 new infections in the world. So some of that was drawn from studies, others is modeled. And that's just the reality of measurement in health. You don't know the exact number, but you can certainly look at trends over time. So the Lancet Commission will say that their indicator is valid. That sure they pretending that throughout the world more people die when it's above 20 degrees. Not pretending, they're using that as the measure. But if you're using that measure year on year, you can begin to see these changes and measure them. I don't know. Can others jump in? I know there was a lot of richness in your questions. Yeah, so the threshold is from getting stuck in and measuring what's happening in your district.
Uh,
Sorry, Gloria, there's a question on heat wave, and this is again complex. That I think we are moving towards a more standardized definition, and here the one that I like is more than 1 or more days when your temperature is above 90% of the hottest days in a year. So let's say that out of the 365 days in a year, you work out what is the hottest 10%. So you know, and so those are the 10% hottest days. And if you're getting 1 or more days above that threshold, that's called the heat wave. And so it's the main feature of a heat wave is that it is more than 1 day of very high temperature, and you've seen up to 10 days in some of the countries where heat waves occur. You're getting this continuous, and the body can probably cope with 1 hot day, but more in a row, especially nighttime temperatures, is a major physiological burden that causes really marked impacts.
Fantastic. Thank you, Matthew. See, Sunanda Ray has raised her hand. Please proceed.
Yeah, thanks very much. And thank you for the excellent presentation, Matthew. I just wanted to make a couple of points. One is that, you know, we should be using this to show people the importance of collecting good quality health information, because I think in many primary care clinics around the region, people are collecting data often without knowing how it's going to be used. So quite often the quality isn't great. So in order for us to show this, to use these indicators, we need to have good quality health information, routine data collection. The other thing is also intersectoral collaboration, working with the Met Office to get data on temperatures, because I think they collect the data, but because people don't use it, you know, we don't link it up. And then my other point is about the heat issues, because the relationship between heat is with cardiovascular disease often. I wonder whether it affects our elderly community at an earlier stage than 65, because we know that hypertension, for example, starts at an earlier age in many African communities. So that's another thing we should be looking out for. I think the proportion of people over 65 in most of our communities, apart from South Africa, is only about 5%. So to show a change is quite difficult. But if we asked our cardiovascular specialists to start looking at this data, I think we might find that it starts at an earlier age, even at 50 or 55, because we hear anecdotal evidence of people suffering heart attacks, etc., or strokes when they're in their mid-50s, when the temperature goes up. So we actually need to document it. Thanks very much.
Thank you.
Thanks, Sunanda. Those are all excellent points. Yeah, and you're right. If you have a chronic disease, or if you're in an area that where life expectancy is lower, the vulnerability of a 55 or 60-year-old is probably similar to a 65-year-old or even sometimes a 70-year-old in a wealthier country where there are health services and other things in place. So the impacts of heat probably occur at a lower age. So an impact of heat on cardiovascular disease probably do occur at a lower age in poorer communities than in high income. Yeah, I think that's again important. And you're showing once we start measuring, we'll answer these questions. There was one interesting thing about the cholera outbreak. So unfortunately, a lot of the science does have complexity. In other words, let's say there's a flood, or if temperatures have risen in an area, and you won't get a cholera outbreak straight away. Okay, so let's say after the floods in Mozambique, you didn't see a cholera outbreak, at that time. It will take, there's a lag or a delay from the exposure to the outcome. And even with something like preterm birth, you'll get a heat wave. you're not on that day always going to see an increase in preterm birth. So sometimes it will take 3 or 4 days for the inflammatory response from heat to trigger preterm birth. So there's unfortunately are lags. Also with death. With death, when it's warm, you'll get an increase in death, but you'll see an increase also 3 or 4 days later as the body decompensates. So the one outcomes, things like motor car accidents and violence, those are more pleasing to measure from a mathematical point of view, because it was hot and you're getting a motor car accident or homicides. You're pretty sure it happened on that day.
Thank you, Matthew. We're running out of time, but I just want to ask, there are a lot of policymakers and other stakeholders on, in this session who are probably asking, so where do we start? How do we start looking into indicators? So what advice do you have for them in terms of data? What data should they be looking at to start identifying these critical indicators? Thanks.
Yeah, thanks, Gloria. So the one thing is a little bit low hanging or easy wins, and that would be the first one that's on the screen. And that's just that the Lancet does. You get the Met Office together, or the climate services, the South African Weather Services in our case. You get them together with the census data, and you work out the number of population exposed to a dangerous threshold, and we can make that. We can determine that threshold from evidence. So I think that's a relatively easy one that the country could get stuck into. And if you had 2 clever people in a room, and you'd probably be able to get those measures in a few weeks. So that's an easy one. And then I think what I would suggest is trying to find some facilities that have daily data, and again link that daily data to the people who have the climate data and try and analyze something, and working towards separating the impacts of heat from natural variation towards those that from climate change. That's where you're heading. So I think it's a road. Go first generation, then second generation, and then third generation indicators. You're kind of building up. You're going up that steps.
Wonderful. Thank you so much. Matthew, this has been a fascinating presentation, and just to thank you for your time in sharing this. As I mentioned to everyone else, we will share the slides, and if you have any further questions, please feel free to still put them in the chat, or you can send an email, and we'll forward these to Matthew, and he can respond to your questions. So thank you, Matthew.
Excellent. Thank you, everybody.
Just before we go, if I can just ask Caroline to just jump in and give you just a few Chance Network updates. Caroline, over to you.
Thank you, Gloria, and thank you, Matthew, for the wonderful presentation. So we have a couple of updates. We are currently in the process of transitioning the Secretariat from the University of Botswana to WITS. We can all agree that UB has done a wonderful job as a Secretariat since the inception of the network. And in addition to the change in the Secretariat, we also developed a constitution to help us govern the network. And we want to invite more people and more organizations to be part of how the network operates. So we'll be sharing more information with members in due course, and also look out for an invite to the first annual General Assembly this first quarter of 2024. And we also want to invite members to share some of the work that they're doing in their countries. Some of the members are doing quite impactful work on climate change and health in their respective areas. And if you'd like to present the work that you're doing in one of the webinars, please reach out, or you can also send us details and we can also share with members. I think the whole mandate of the Chance Network is for us to learn from each other and also build capacity and also help others learn from what we're doing. So yeah, thank you. I hope I haven't missed out on anything.
Thank you very much, Caroline. So everyone, thank you for joining this webinar, and happy Valentine's to you if you are celebrating. I wish you a wonderful day further. Thank you. Goodbye.
Thank you.
Thank you.
Thank you. Bye.
Thank you. Thank you. Bye.
Thank you, everyone.